transmission. As was mentioned, my name is Richard Berri. I'm a surgical oncologist in Detroit, Michigan. We are at St. John Hospital Medical Center that is part of Ascension, that is an organization that delivers healthcare around the United States. Thanks to Glenn and the group for asking me to speak tonight. The intent of the talk tonight, and I'm going to spend about 30 to 35 minutes, I hope, going through what you can see there. I hope you can all see the multidisciplinary treatment of peritoneal surface malignancies. We started our program here about 6 years ago, and we've been able to accumulate a good amount of experience and data that I'll share with you as well. And what I hope to do is give a talk that is centered around the patient and try to explain to you what to expect from a potential HIPEC evaluation, and explain a little bit about what the indications are for HIPEC, what the problem is that we face with the different diseases. I'm going to talk a little bit about the management and the diagnosis and evaluation of patients, the treatment, which is cytoreductive surgery, HIPEC, and the technique. I'll share some data, and then through the talk, and if we have time, I'll discuss some cases as well. So I wanted to talk first and explain, patients will come to me often when we talk about peritoneal malignancies, and will ask me first, what is the peritoneum? And so if you can see the slide here in the schematic there on the right of the slide, that's a picture of the cross-section of the abdominal cavity, and the back is down. You can see it labeled back, and front is up. And this is kind of looking at the way CT scans look at the intra-abdominal cavity. You can see the red line there is actually the peritoneum. And so the peritoneum is a thin membrane that lines our abdominal and pelvic cavities and covers the viscera of the abdomen as well. And it's a thin layer of connective tissue. And you can see that when we talk about this, it's not a very well-known disease site because it is not discussed that much relative to other solid organs that are discussed and are much more common. And so peritoneal cancer by itself is somewhat of a rare type of cancer, but that's really what we'll focus on today. And so peritoneal carcinomatosis is really just the spread of tumors within the abdominal cavity, including surface involvement of the intra-abdominal organs. And I've heard other surgeons before talk about and give analogies for what the peritoneum is by comparing the abdominal cavity to a room. And if that room, for example, has a table, chairs, other objects, those are the organs. And if the room had wallpaper, that would be the peritoneum. And so you can imagine on the wallpaper or the peritoneum, there can be tumors, cells, and tumors. And when we remove the peritoneum, if there are tumors, we prefer to remove really the entire sheet of the wallpaper rather than just take small portions. And so that's a little bit about the peritoneum. And if you can see here, this is one of my patients. I'm holding up really the left upper quadrant to my left hand there, and to my right hand, the left lower quadrant peritoneum that we've dissected away from the abdominal wall. And that whole sheet of peritoneum, you can see here, has tumor cells on it. And so all those, and I don't know if you can see this, but I'm using the pointer here on my slides. All these implants here are all mucinous tumors from a patient with appendiceal cancer. And so this is the peritoneum here that we remove if it's involved with tumor. Now, sometimes patients will ask me, and you may wonder, do you always remove the peritoneum? And do you do that for all patients? And really the answer is no. We do it when there is tumor on the peritoneum, or if there's an area that's suspicious that we think there was tumor, even if it was treated previously by chemotherapy. But if there is normal peritoneum in areas of the abdomen, and there's no sign of tumor in that area, and we don't suspect there was ever, then we don't routinely remove all the peritoneum unless needed. And that's a question that comes up. And so what is cytoreductive surgery? People will talk about cytoreductive surgery or debulking surgery, which is basically removing the tumor from the abdominal cavity. And you can see here in some of these pictures, this is a picture of the appendix with mucinous tumor emanating from a ruptured appendix. And this in the upper right is what that mucin that comes out of the appendix can produce. And so all this is in one of our patients' abdominal cavity. And this is a large mass, which is the omentum, which is a fatty layer of tissue that we all have. It serves as an apron of the abdomen and helps do some physiological things, but unfortunately it's a common place of tumor implantation. And so debulking surgery or cytoreductive surgery is really just that, removal of the tumor. And we aim to completely remove all the tumor. And many would argue that when you talk about cytoreductive surgery and debulking surgery and HIPEC, that really this is probably the most important part. And so many times people will talk about HIPEC and say, well, what is the HIPEC and what are the details of that? But it's extremely important to note that the most important first part, at least, and perhaps the most important part overall, is complete removal of all the tumor in any patient that we take the surgery for this operation. And really, this is the main source of potential complications as well. And people will ask, what is the complication rate of HIPEC? And I always tell them, well, it may not be that the HIPEC is really causing the complications, it's the cytoreductive surgery and taking out all the tumors, which you can see there on the slide, if you can still see these, is really the main part of the operation. And so this can last anywhere from 4 to 20 hours, or shorter or longer, depending on the extent of the cytoreductive surgery or the debulking. We remove any organs that are involved with tumor that we cannot remove the tumor from those organs. So things like the colon, the omentum, the gallbladder, the spleen, the uterus, the ovaries, and as I showed you previously, the peritoneum, including the peritoneum on the diaphragm, which are the muscles that separate the chest and abdomen and help in breathing, the capsule of the liver, perhaps parts of the small intestine, parts of the stomach, and really anything that has tumor involved on it that we can remove, but of course, at the same time, still attempting to preserve some quality of life. And so cytoreductive surgery is really that, complete removal of all the tumor. This is a similar slide. And so most commonly, this is performed through an open abdominal incision. We have done, and others have reported, laparoscopy for debulking and HIPEC, which would be, unlike this picture, a series of small incisions. And I'll show a picture of that as well. But we reserve laparoscopy for patients with very low volume disease, where we can remove small tumors through laparoscopic port sites and then do a laparoscopic HIPEC. But the traditional approach to this operation is a long midline, and in most cases it may be even longer than this. And what we do is enter the abdomen, assess the tumor burden, and determine if complete cytoreduction is possible. And the way we do that is something that is called the Peritoneal Cancer Index. And so I will tell my patients about this and talk to them about this before the operation and even afterwards. And patients, when they learn this, will actually ask me after the operation, what was the PCI? And so the PCI is a scale here that you can see, which determines really the volume of tumor. And so when I say we're going to do cytoreductive surgery, it's important to know how much tumor is there, and we have to have some scale that can quantify that. And Dr. Sugarbaker came up with this, and you can see here he divides, and the abdomen is divided into quadrants. And so you can see here 1, 2, 3, and then the quadrants labeled here in the abdomen. And there are 4 areas within the mesentery of the small intestines, and you can see those labeled here. And so in these areas, we then assign a score of how much tumor we see in each of those quadrants. And you can see at the upper right side here, if there is no tumor seen, for example, in this area, let's say in number 1, then there's a 0 score given. If we saw more than 5 centimeters of tumor or a confluence of tumor, we would give 3 points. And so you go through each of those and you add up the numbers, and 0 means there is no tumor in any area, and 39 means there's tumor really on every visible structure inside of the abdomen. And so we use that number to be able to discuss with patients and colleagues really the volume of tumor, and it gives us a good idea of if cytoreduction is possible and if it's appropriate, really, especially in cases of colorectal cancer, where we think that if this number PCI is above 20, for example, then we think for patients with colorectal cancer that surgery may not be that beneficial. Now, with tumors of the appendix, for example, especially mucinous tumors, even if this number is very high and there's a very large volume of tumor, we think it's still appropriate to move forward with resection because the behavior of the tumor is less aggressive than colon cancer. And this is an example of that. This is a study that was done in France, actually, that talked about the PCI for colon cancer. So if you or a friend or someone has colon cancer and they want to know if they're a candidate for HIPEC, I discuss with them this number. And I tell them, if the number is less than 20, this PCI, Then, as you see here, for example, in this group of patients with a PCI of 1 to 6, which means very, very little tumor in the abdomen, then we think they have a good chance of overall and prolonged survival. However, if the number is more than 20, we're concerned that they may not have a better survival as opposed to giving them chemotherapy systemically alone. And so again, this is for colon cancer, not for the other disease treat, but I think it's important to note. And so then at the time of surgery, as I mentioned, when we assign the PCI score, we also assign a CCR score that your surgeon may talk to you about, or you could ask about after the operation. And really what it is did we remove all the tumor? And what we would hope is that the answer is yes. And we would hope that at the end of the operation, we've achieved a CCR, or a completeness of cytoreduction score of 0, which means no visible tumor is left. If it's a CCR1, that means there's residual tumor less than 2.5 millimeters, and that can be acceptable, and we can still then move forward and perform the HIPEC, or the heated intraperitoneal part of the surgery. If, however, there is residual tumor that's larger and visible to the eye, especially when you get more than 2.5 centimeters, then we think in this category, CCR2 and CCR3, that the benefit of heated intraperitoneal chemotherapy may not be as much, because we feel that the chemotherapy may not penetrate those tumors to a depth that would be of an advantage to a patient. And so, in our practice at least, I perform HIPEC for patients when we can achieve a CCR 0 or 1. In some rare exceptions, for example, refractory ascites, or if the patient has reaccumulating fluid in the abdomen, we may do a HIPEC to try to treat that fluid buildup, even if it is a CCR 2 or 3. And this is how things we would hope would look at the end of the operation. You can see here, this is the intra-abdominal cavity of one of our patients who had extensive intra-abdominal peritoneal carcinomatosis. And after we're done with debulking before the HIPEC, we survey the entire abdomen and ensure that we see no residual tumor left. And so cytoreductive surgery, the long-term results are related to the ability of the surgeon to remove all the tumors. And we really think this is important in terms of the possibility of recurrence for a patient with really any type of cancer. And so the long-term benefits of cytoreductive surgery are related to the size of the deposits of the residual tumor, if there is any. And really quite logically, the smaller the size of residual tumors, the greater the chance that the patient will respond to the heated intraperitoneal chemotherapy, and less likely the patient is to recur. And so the key is really just removal of all the visible tumor. Now, once we've done that, and we're kind of now going through just the process of what we do with patients, and then we'll talk a little bit more about different diseases. So when debulking is complete, we've gone into surgery, we've removed all the tumor, we now, if we've achieved complete removal of the tumor, we now move into HIPEC. And so what is HIPEC, people may ask? Well, it's heated intraperitoneal chemotherapy. And the rationale for this is, as follows in some cases. Intraperitoneal chemotherapy allows for very high drug concentrations to be reached, and tumor cells colonize insert surfaces very rapidly. And so the intent is to add the chemotherapy in a perfusate, or a fluid that we add with the chemotherapy, into the abdominal cavity and add heat. And this has a direct lethal effect on cancer cells. And really the heat potentiates the toxicity of the chemotherapy. And so if there's microscopic tumor cells on the surfaces left over that we cannot see, or very, very small areas we potentially could see, the heated chemotherapy that is instilled into the abdominal cavity is done so in an effort to destroy any cancer cells and to help prevent future recurrence. And here's a schematic of how that looks in the operating room. You can see here the fluid is being circulated into the abdominal cavity through a series of cannulas or plastic tubes that we use. And we gently agitate or shake the abdomen during this procedure to make sure all of it is distributed in the abdominal cavity. And then the fluid then returns back to the machine. Here you can see that has a heating mechanism on it that heats the fluid. And then we instill the chemotherapy into this fluid, and it continues to circulate throughout the abdominal cavity. Now, what I've shown here is the closed technique. There are some who perform the open technique, so they do this same schematic type of picture, but they use a different type of system where this abdomen or the abdominal cavity is left open, and they gently distribute the perfusate and the chemotherapy manually or with a series of tubes or cannulas. In the United States, in most centers, we do this in a closed technique where this part of the incision is closed during this perfusion. You may ask also, what is happening during this? And it's extremely important during the perfusion, before the perfusion, and really after the perfusion, what happens, because the role of anesthesia in the operating room and perfusion play a very, very big part of this. And we have to optimize you or the patient before we start the HIPEC, because the HIPEC, as you can imagine, heats the patient. And so before the heated chemotherapy is instilled, we go through a series of steps where we administer fluid, we cool the abdominal cavity to a particular degree and cool the core body temperature before we instill this heated chemotherapy, because we expect a rise in the body temperature. And so the anesthesiologists and the CRNAs play an extremely key role in maintaining the body temperature at an acceptable rate and maintaining urine output and volume that we give you in the operating room at a reasonable level. Because sometimes the chemotherapy drugs that we can use can be toxic to your kidneys, and to prevent that during this part of the operation, and really for most of the entire operation, you will receive lots of fluids in the abdominal cavity and into the venous system. And then this will result in sometimes post-operative changes such as swelling and edema, and sometimes an increased risk of complications. We've tried our best to limit the fluid intake, but it's an essential part of the operation historically, and patients still who have this operation end up receiving a lot of intravenous fluid. So here's a picture of that. Again, here's the cannulas that take the fluid in, and the cannula that brings the fluid out. These are temperature probes that monitor the temperature of the fluid that's going in and out. And then we use something that's a little bit different than most centers, a pressure monitor, to monitor our intra-abdominal pressure. That really helps us regulate the temperature and the flow of the perfusate and helps ensure a safe perfusion. This is an example of that. These are examples of the machines. This is our current model that we use. Again, these have a heating mechanism, and we instill the fluid with the chemotherapy mix, then it goes into the abdominal cavity, then out in a continuous cycle. And this lasts, in most cases, for 90 minutes. That depends sometimes on the type of tumor that we're treating and the type of chemotherapy drug that we're using. For colorectal cancer and for appendiceal cancer, we most commonly use mitomycin C, and we do the perfusion for 90 minutes. For other cancers like gastric cancer or mesothelioma or ovarian cancer, we may use other drugs such as cisplatin. And in those cases, we may only perform a 60-minute perfusion. There are other drugs that we use for unusual tumors or for recurrent tumors. One of those you may have been told by your surgeon or heard of. It's called melphalan, and that's a drug that we use sometimes in the recurrent setting. And we use that for 60 minutes only. And so all the drugs, and we could go on and on about that, but I don't think that's the intent of the talk, but it's important that you know that the types of drugs that are used and the duration of the heated chemotherapy intraoperatively, and you can talk with your surgeon about that. And as I mentioned before, we showed that picture of the big incision. This is a case of ours where we use just these two small incisions here to have the inflow and outflow cannulas and perform a laparoscopic perfusion or laparoscopic HIPEC on a patient with limited disease. And so it's not always the case that we have to make a very large incision and have a very invasive operation. And so you may ask, and people may ask us, am I a candidate for HIPEC? And I think it's important to talk about this and really what determines if someone is a candidate for HIPEC. Well, it really depends on the biology of the disease we're talking about, the histology or the way the tumor looks under the microscope, and the grade of the tumor. Is it a low-grade tumor? Is it a high-grade tumor? And I'm mostly here referring to tumors of the appendix and tumors of the colon, and in some cases, tumors of the stomach or the ovaries or peritoneal mesothelioma. And so biology of the disease or the type of disease is very important. The function of the person is extremely important and could be the most important factor. The performance status, which is a term that we use to describe if a patient is functional or not. So if you function normally and you do normal daily activities and you're able to do everything you could, before this onset of disease, then your performance status most likely is what's called 0. And so 0 means a fully functioning person who really could tolerate any type of operation like this. As the number increases, 1, 2, 3, 4, that means the function of the person is much, much more compromised. And so we caution operation, especially operation with HIPEC, in patients whose functional status is not good. And sometimes the patient and the family and the team taking care of the patient can best determine that. And so the biology of the disease and the function of the person, if you take anything from this talk, those are two very kind of general statements, but very important in terms of selecting patients who will benefit from this. The amount and location of disease is also very important. And so how much tumor is in the abdominal cavity? Is there tumor outside of the abdomen? People will ask, well, am I a candidate for this operation if I have lung metastases or liver metastases? And I will say, overall, it depends. And this is not in some centers and in ours also. I don't have any standard rules against this. And so, for example, if we think a patient has, and some of the literature has described 3 or less liver metastases that are removable, then you may still be a candidate for debulking and HIPEC and liver resection, for example, in the setting of a colon cancer. For lung metastases, it's similar. If those are removable and the volume is low, then there may be some option for patients still to undergo evaluation for HIPEC. And so these are important questions to talk about and to think about. So the biology of the disease, the function of the person, and the amount and location of the disease are key when evaluating someone or when trying to figure out if you're a candidate for this. And so what are the indications for HIPEC? Well, I've listed these here, and these are all patients that for types of cancers that I've operated on, and many have throughout the country and throughout the world. Appendiceal cancer, colorectal cancer, peritoneal mesothelioma. I'm going to talk most about appendix and colorectal cancer today. Peritoneal mesothelioma, primary peritoneal cancer, ovarian cancer, gastric cancer, small intestine cancers, liver cancers, different types of sarcomas. There are a series that are of limited patients, but with some experience in pancreas cancer and other disease sites. And so, while we would not say these are the most standard indications, some of these I have listed here. For example, appendiceal cancer, peritoneal mesothelioma, I would say ovarian cancer, and now especially with new guidelines that I'll discuss, colorectal cancer. This discussion should be part of the discussion in patients who have these disease sites that have intra-abdominal spread who are reasonable candidates based on my last slide. So these are some of the diseases that are possible indications for an evaluation. So what will happen when I go to a HIPEC treatment center? And so what should you expect as a patient? And what we've tried to do, at least in our center, and I know in many centers that have experience, we've tried to provide patients with really a multidisciplinary evaluation and a team approach where we have a patient seen by many different people at an evaluation and very, very carefully review and scrutinize all of the past records to help determine if a patient is a candidate for this. And so I've talked about some of these things. And so what should you expect us to review? Well, as I said, to me, we have to see how a patient is feeling and how they're doing overall. Are they able to do daily activities that will even allow them to be a candidate for this, let alone all the really medical factors or the factors of the tumor. And so the performance status of the patient, the history and physical of the patient. We use labs that have sometimes included tumor markers, which are numbers that you may have heard about that can be elevated in certain types of disease. For example, CEA, which is a common tumor marker that can be elevated. That's just a simple blood test, but can be elevated in cases of colorectal cancer or appendiceal cancer or other types of cancers. We review or redo imaging of the chest, of the abdomen, of the pelvis, to see if there is a disease in those areas. And I mentioned the PCI before, which was the peritoneal cancer index. Now, we can't base that solely on imaging, but we can sometimes get an idea of what that number is by looking at a CT scan or an MRI of the abdomen to help us or clue us in about how much disease may be in the abdominal cavity. But I have a slide about that as well coming up. Endoscopy, colonoscopy, or looking into the colon, or looking into the upper GI tract. Laparoscopy. Sometimes I will take patients to the operating room in the early part of an evaluation and just make a small 1 to 2 centimeter incision, put in a camera and look into the abdomen and say, well, is this patient a candidate for further evaluation or further debulking in HIPEC? And I'll base that on what I see. Because as I'm going to mention, CT scans, MRIs, PET scans all really underestimate how much tumor could be in the abdominal cavity. Medical and cardiac clearance, the patient has to be, or you have to be in good condition to have this operation. Nutritional parameters are extremely important. Detailed review of past treatments. We have a consensus meeting where we have specialists in medical oncology, radiation oncology, surgical oncology, different surgical specialties, pathology, radiology, all meet to discuss these cases and determine if we think this is a good option for patients. There are different scoring systems, and some of that I mentioned, that help us kind of stratify patients to see if we think they are good candidates for this operation. I mentioned some of those to you before. And second opinion, patients will come to me and as a second opinion, or they will go see another center. And I always encourage that. If somebody is seeking many opinions, the more information that you have, the better. And so I encourage that if you're going to a center that has experience. And so the multidisciplinary team is really what I've talked about already, but who is involved in that? Really, it's for a program that is well designed and that has experience. It's really a hospital-wide team here, you can see. And I can't stress this enough. The surgeons, the anesthesia group as a whole, the CRNAs and the anesthesiologists, the perfusion team, the medical oncologists, all the nursing, everyone really that I've listed here are key. And in our program, for example, we have a core team that includes a surgeon, myself, and one of our CRNAs and anesthesiologists and a perfusionist. We really have been together over the last 200 cases. And so having a team like that is a standard for every case helps really in delivering the best quality of care. And so I encourage you, when you go to centers or have an evaluation, to ask and kind of talk a little bit about the team that will be treating you. And that importance of the treating centers was shown here. University of Pittsburgh and others have published data about how many cases a center should perform to have the experience necessary to deliver good care to patients. And so it's extremely important as you look around and try to determine where you'll seek surgical care to look at the center. And people have suggested that after 90 cases or after 100 cases or after 180 cases, the center itself, the surgeon and his team, may then have the experience that will help you have a better quality outcome and perhaps even a better survival. And so it's important just to ask when you go to centers their level of experience. And you can see here, this is to date, we've surpassed 200 cases and continue to go in that direction of providing as high quality care as possible. And so how is peritoneal cancer diagnosed? Now you may know that or may be asked, and it can be diagnosed in many ways. Unfortunately, at the time of surgery for some other reason. So if a surgeon or an institution does not have a peritoneal malignancies program, that patient should be referred. And so this happens when somebody is taken to the operating room for maybe an appendectomy, for appendicitis, or for a colectomy for colon cancer, or for a gynecological procedure for a presumed ovarian tumor or ovarian benign finding. And the surgeon then finds to their sometimes unexpectedly evidence of spread of one of those tumors. And so what do they do then is really a key point. And we will see many patients who've had this same scenario. And we would hope that by talks like this and by education of the medical community and patients, that we would hope that at that time, when that's discovered, the patient is then referred to a center that can at least evaluate them and possibly help them. So at the time of surgery is a common time that peritoneal cancer is diagnosed. After surgery, sometimes it's diagnosed from surveillance CT scans or MRIs, or from symptoms patients could develop. And then sometimes it's the initial presentation. And so the patient may present with abdominal pain or bloating or some finding. There may be a series of tests, including CT scans or biopsies. And sometimes from the beginning, we can diagnose the peritoneal spread of tumor, either from the appendix or from the ovaries or from the colon or whatever it may be. And so these are kind of the three most common time points that peritoneal cancer can be diagnosed. And symptoms can be vague, unfortunately, like many different cancers: bloating, nausea, abdominal pain, bowel obstruction. In patients with colon cancer, there is CT scans are usually done after they've had their colon cancer removed, every 4 to 6 months in some cases, and surveillance scans can sometimes see tumor and sometimes they cannot. Tumor markers, sometimes in surveillance, will often be elevated, sometimes they will not be. And so it requires a dedicated team that is conscious of the possibility of patients who've had previous cancers removed and who are now in surveillance to have a close eye on the peritoneum and have a high index of suspicion of any abnormal findings. And unfortunately, this is why, because this is a patient with no signs on MRI, PET scan, or CT scan of any tumor. But unfortunately, when we do laparoscopy, you can see here these small white areas are small tumors in the abdominal cavity. And so imaging is not 100%. And if there is any suspicion for any patient, whether it's new onset or they've had a history of cancer, then laparoscopy can sometimes be used, which is making an incision and looking in the abdominal cavity in surgery. It is a surgery. It's a relatively minor surgery that's an outpatient operation. So you come in, we take you to surgery, you go to sleep, we make a small incision, put in a camera and look, and if we see anything like this that's abnormal, we may biopsy it or take a portion of that, and then that may help give us more information about what the problem is and really what the extent of the problem is. And so once we diagnose the problem, it's extremely important to talk about patient selection. And so as I mentioned before, any patient, I feel, with peritoneal carcinomatosis from a GI or GYN primary who has an acceptable performance status, that's what I mentioned before about function, who has no signs of disease outside of the peritoneum, in most cases, and of course there can be exceptions, as I mentioned, of the appropriate age and somebody who has limited medical problems, then we really think all those patients should be at least evaluated by a team who has a surgical oncologist, who has experience in this discipline, and who has a team that can do that. So this is a case of a 51-year-old female. She presented, she had no really past medical history, just vague abdominal pain, and question of a cyst on the ovaries. She had a laparoscopy, as I mentioned, by a GYN doctor. That's the procedure where you look into the abdomen, and they saw mucinous fluid in the abdomen. And so they biopsied that, and it just showed mucin, which is a thick fluid-like substance that can be produced by tumors of the ovary or tumors of the appendix. And so that patient was seen, had an evaluation that included a CT scan, tumor markers, those blood tests that I told you were checked, and you can see for the most part they were normal. Patient had then a thorough review, and unfortunately, you can see here on CAT scan, there does seem to be some evidence of abnormal fluid around the liver. This is the liver here. This is the right side of the body. This is the left side. This is the back here. This is the front, and this is a CT scan. This is the spleen. This is the stomach here. So this is not normal. This fluid, or what seems to be thicker than just fluid, perhaps mucin, should not be here. And so this patient then was taken to the operating room, and you can see here what the problem is. This is a picture of the appendiceal base, and so there should be an elongated structure here, which would be the appendix, but it's no longer there. You can see what is mucin coming out of the end of where the appendix was that had ruptured and released this mucinous fluid into the abdomen. And so this is what the source of the problem was for this patient. The patient was then taken to the operating room here, and we won't have to look through all this, but you can see the patient then undergoes multiple intraoperative procedures. The operation can take a long period of time, as I mentioned. This operation took 11 hours. This patient got 15 liters of fluid, but fortunately, the pathology was all low grade. And the patient was left the hospital in about a week and did very well. Now this patient is further out from the operation, but we expect these patients with low-grade tumors to do very well, despite long operations. And so you shouldn't be misled that a long operation that requires us to remove lots of different areas can be something that is not, that you're not able to recover from. People can recover from these operations, and especially in low-grade disease, we think they can recover and do quite well for a long period of time. Here's another picture of the appendix with a tumor, mucinous tumor coming out of it. And this is why Dr. Levine from Wake Forest in an earlier study looked at the survival of patients with appendiceal cancer, and you can see there the green arrow is showing patients who had low-grade tumors, and the red is showing high-grade tumors. Low-grade tumors, we think the median survival can be in more than 10 years. And again, these are low-grade mucinous neoplasms of the appendix. There's been a lot of talk over the years about the type of tumor of the appendix and the histology of the tumor. And there have been multiple different names and abbreviations, but I think we all agreed now that there's either low-grade tumors of the appendix or high-grade tumors. Low-grade behave very well if treated appropriately, usually with debulking surgery or cytoreductive surgery and HIPEC. High-grade tumors, unfortunately, are less benign and behave more malignant in a malignant fashion and can be quite aggressive. You can see here the survival may not be as well. That doesn't mean that these are not candidates for operation, but they should be treated a little bit differently than patients with low-grade disease. And that may include chemotherapy in the vein or a different approach, not just surgical debulking and HIPEC, which really is most appropriate for patients with low-grade disease. People will also come in and ask us, and I think it's important to mention, and Dr. Sugarbaker just published this recently, they always ask me and ask us, well, we had appendicitis, or a patient had appendicitis, or surgeons will call me and they found a mucinous tumor of the appendix, and they're advised to then go back and remove their right colon. And you may have heard about this. And we think that that may not be necessary in a lot of cases. If you see this picture here, you can look at this. You've had a perforated appendix. The pathology showed that some of the mucin escaped from the appendix, but it was a low-grade type of mucin, which is what this is the abbreviation for, an older abbreviation. If that's the case, then simple appendectomy alone and debulking and HIPEC is very appropriate without the need for right colon removal. However, if you look to the far right here, this is a more aggressive type of tumor, and these two categories, poorly differentiated, which means a higher grade tumor. Then we recommend right colectomy, debulking, and HIPEC. This is for true adenocarcinoma of the appendix, which is in this category. But however, again, if it's moderately differentiated mucinous tumor or well differentiated, then perhaps only appendectomy, debulking, and HIPEC is necessary. And so it's important to ask your surgeon and to get the proper information about exactly the type of appendix cancer you may have, or one you know may have, because they may then be offered a different type of operation. So the bottom line really is for appendiceal mucinous tumors, we try to remove all the disease. And again, that can take a long time, and that can be a big operation, but patients will benefit from that. The tumor can recur despite doing that. The duration of surgery, as I said, can be extended. The recovery can be quite long. Second or even third HIPECs are possible when those tumors recur. I recently saw a patient who had a HIPEC 14 years ago for appendiceal tumor by another surgeon in a different state than where I am. But the tumor came back after 14 years, and it was a low-grade tumor. And we just recently took that patient back to the operating room and removed the tumor again and did a second HIPEC. And so it's possible that that can occur. Preoperative condition for all patients and for all people who are going to be evaluated for this is extremely important. And your preoperative preparation and condition directly relates then to your chance of recovery. And so we'll talk quickly about colon cancer. There's about 150,000 new cases each year in this country. Unfortunately, about 25% of those may develop peritoneal metastases. And so that's almost 20,000 people. There was a randomized trial in the Netherlands back in 2003 that compared just chemotherapy and HIPEC for patients with colon cancer that had spread into the peritoneum. And that did find a survival advantage for patients who were treated with HIPEC and cytoreduction, with an increase in their median survival. So this is an older study. The type of chemotherapy that was used then is different than the type now, but it was the first randomized trial and still the only one it did show a survival advantage for patients with colon cancer who had peritoneal metastases, who had HIPEC, and of course systemic chemotherapy as well. And so this sparked interest in the community of HIPEC surgeons and oncology. And since then, since 2003, there's been several other studies and really a large interest in patients with colon cancer, trying to determine if HIPEC will help those patients. And encouragingly, these are the NCCN guidelines just recently, which are the National Comprehensive Cancer Network, which is really what oncologists throughout the country and perhaps world follow. And you'll see for the first time, there's a statement about HIPEC in these guidelines, which is very encouraging. And this is for colon cancer that is spread to the peritoneum. Complete cytoreductive surgery, which means complete removal of all the tumor, and intraperitoneal chemotherapy, which means HIPEC, can be considered in experience centers, as I mentioned, for select patients, as you can imagine, with a good functional status who have limited peritoneal metastases, for whom R0 resection can be achieved. That means for whom we can take out all the tumor. And so finally, we're getting support from a national group that says for colon cancer, this may be a valuable approach. And there's data to support that also, data that's been done and data that we still have. It shows median survivals much longer than we would expect when you look at the 5-year survival rate of patients with colon cancer with peritoneal spread of not even 5% in most series. There's a group, the American Society of Peritoneal Serous Malignancies, and other groups that have had consensus papers about the treatment of colon cancer using HIPEC, and all of us who have a high volume of this type of tumor tend to follow these guidelines. And it talks about the drugs that we use, the type of perfusion that we do, and so we try as best we can to standardize this across the country, at least in the United States, to deliver a high quality outcome for the patients. And then the results of some of the work that this group has done that we were included in looked at over 1,000 patients with colon cancer, and we found that in those patients who had limited disease with a good performance status, if they had HIPEC, they could have a much prolonged survival as opposed to just chemotherapy alone. Go over a couple of other disease sites. Mesothelioma of the peritoneum, I would say, as much as anything else, is one of the most standard indications for HIPEC. And we know that systemic chemotherapy for mesothelioma of the peritoneum is rather limited. Although there are newer agents now, we still strongly support the role of heated intraperitoneal chemotherapy and debulking for mesothelioma. And there's been many studies on that, and it's just an example of that. There's been over 20 articles with over 1,000 patients that have shown 5-year survival rates up to 40% with debulking and HIPEC for mesothelioma of the peritoneum, in particularly epithelioid type, which may be a subtype of mesothelioma. Most recently, there's even newer attention to the treatment of mesothelioma of the peritoneum using things like heated intraperitoneal chemotherapy, early post-op intraperitoneal chemotherapy, and normothermic intraperitoneal chemotherapy, which means regular temperature after putting a port into the abdominal cavity. And Dr. Sugarbaker and others have had some early success in the long-term survival of patients treated aggressively with mesothelioma of the peritoneum. And we currently have a patient that we're putting through this protocol as well that's doing very well. Gastric, ovarian, primary peritoneal cancer, all these, there is a role for HIPEC, we believe. Patient selection is extremely key. Timing of the operation is important, and a multidisciplinary team is essential. The standard in this country for gastric cancer is somewhat controversial. We would not say that it's the standard approach for patients with gastric cancer, but if someone has gastric cancer with peritoneal spread, we would advise they be seen and evaluated in the center with experience, and each case really is very, very selective. And so if there's limited disease and the patient has done well with systemic chemotherapy, we would consider in some cases gastric resection and HIPEC for those patients. Ovarian cancer is much more standardized in this country, and there's been a lot more data and a lot more success, especially in patients with ovarian cancer that has recurred after the primary treatment. So just wrapping up, people will ask, what is the complication rate of this procedure, and can I recover from this? And we would say yes. And these are all big centers throughout the country showing their mortality rate. And so these are all, there's 4 centers here that I've shown. I've taken the names off the other centers, but this is our center here. Mortality, which is death with the surgery, in the first 60 days in this center with a large volume is only 1.9%. Our 90-day mortality rate is 0 for these 215 patients. Other centers, 133 patients, 0% 30-day mortality. And in this large series, only a 3.8% mortality in the first 30 days. Very comparable numbers to any major oncological operation. Morbidity or complications, again, you can see here, 30%, 23% is ours. These are more major complications, grade 3 or 4, 30%, 42%. And length of stay, you can see here, ranges anywhere from 9 days to 15 days, and these are all very reasonable numbers. And so asking or looking at that question, can you recover? We published our own data looking at life after HIPEC. We asked our patients and we sent them a questionnaire about did they recover, how was their recovery, and we got favorable responses. And it showed that, and this is a published study that we can refer to or discuss later, it showed that almost 90% of our patients by the 3-month mark had a very good recovery and could return to some normal quality of life. And so I'm here in Detroit, Michigan. We have a team that's been developed over the last 6 years that I mentioned many of them already. We have a surgery team that has been put together, an anesthesia team, a pharmacy team. We have medical oncologists who specialize in peritoneal cancer. We have an individual nurse practitioner and coordinator and team that is sees and evaluates all patients through my clinic. We actually have a dietitian for our patients alone and other support staff that make quality of care delivered, we think, very high. We also offer on-campus housing. We have 6 fully furnished houses on the campus that provide transportation back and forth to the hospital if needed during surgery. We've taken almost 300 patients to the operating room. And as I mentioned, our mortality rate is 0. We've analyzed our cases and looked at the different types of cancers, and you can see the morbidity there again. We have about a 23% morbidity or complication rate in the first 90 days. And these are major complications. And our length of stay is about 10 days. So these are just important, not to just talk about my data, but for you to understand, and wherever you are, ask centers and surgeons and others about their experience, and really any surgeon who does this, all we want for you is the best outcome and to have the best quality of life after the operation. And so patients with complete debulking followed by HIPEC, we think, appear to have significantly improved survival compared to those who only get best systemic chemotherapy. And this is for sure true for appendiceal tumors, for mesothelioma, and perhaps colorectal cancer. Appropriate patient selection is key. Further trials are needed to really get more substantial data to support this. And we all feel that evaluation by a team, including a trained surgeon, will help benefit patients and provide them with the best outcome. And so I'll stop there, and maybe we can talk more. And I think